for being here on this gorgeous day in the afternoon. I know that I'd rather be outside, and I'm sure you guys would too. So I'll try to go relatively quickly to get you out of here. And since you did show up, you do get candy. So we'll start it here and pass it around. And I got enough for about 100 people, and there's definitely not 100 people in this room. So you can take a little extra. Okay. So you made it back around to the best part of your year. Orthopedics is back. Yes. And this is all very high level, deep thought stuff. We'll get into the, requires much less brain power stuff here. So we're going to talk about bones. That's why I'm an orthopedist. I can think this stuff. Anyway, we're going to go through about 10 or 15 different topics, and there's 1 or 2 slides per topic. So it's a little bit all over the place, but I'll try to make it as cohesive as possible. Ask questions at any point, and I will stick around at the end for more questions. A lot of these slides, I know the lectures are taped, but the slides don't have all the answers on them. There's lots of questions. So if you're here, you get some answers. Hopefully your other classmates won't watch the tapes as closely. Anyway, okay. So rickets, as I think most of us know, is a disease commonly seen in children. That's where it's most frequently diagnosed, right? And the classic appearance is a kid with bow legs. Which zone of the physis is involved in the development of rickets? There's a hand. So let's be a little bit more specific. There's a zone in which the cells get very big. Hypertrophy, right, okay. So the zone of calcification includes some different sections, but you have to think about what's happening in rickets and the way the growth plate is deforming, and it's when those cells are expanding in size that the deformity takes shape, because it's a change in the angular growth of the growth plate, right? The growth plate should grow pretty evenly, but it's not. So it's when the cells are hypertrophying, when calcium is being added to them, that they grow at weird angles. And there's different types of rickets. So there's vitamin D deficient rickets, vitamin D dependent, there's resistant, which in the US is by far the most common, and renal osteodystrophy produces rickets as a secondary problem, right? If your kidneys aren't working well, you're not retaining calcium. So this is a slide that you're, especially if you become an orthopedist or maybe an endocrinologist, are going to see about a zillion times, because we actually have to know this stuff for our boards. So see, I do have to know some things besides just bones. But anyway, so the production of vitamin D starts in the liver. We add a 25-hydroxy molecule to the vitamin D molecule, and then in the kidney we turn it into 1,25-hydroxy vitamin D. Now, that matters both in the small intestine and the bone, because if the body senses that there's not enough calcium, it's going to take it from 2 places. It's going to pull it back from the small intestine, and it's going to leach it out of the bones, which is why calcium is so important in bone health. But it's vitamin D that drives calcium in the bones, so you have to have both. And so there's lots of things that will stimulate this. There's lots of diseases, if you go back to this previous slide, that affect both calcium and vitamin D production. But I think the important things to know are, if your serum calcium is low, the body's going to try and steal it from the small intestine through your food, and it will suck it from your bones. If your calcium's great, because you're taking in a lot of calcium, it's going to add it to your bones to a certain extent. Okay, now, it has come up in past on questions about which type of rickets is most common. Not necessarily on the test, but people have just asked this before. Because you'll say, what's the most common type of rickets? And in the US, it's vitamin D resistant rickets, right? We all actually get a pretty decent amount of nutrition in our diet for the most part. What is it throughout the world? Deficient, right? Okay, so just so we're clear on those two, if the question came up, resistant is most common in the US, and deficient is most common in more non-nourished countries. Okay. Next topic, Duchenne's muscular dystrophy. So what age do we typically start realizing that a person would have Duchenne's? 3 or 4 usually, sometimes a little earlier. But 3 is a pretty common age. So is it males or females? Majority, by vast majority, it's males. And that's because the inheritance pattern is X-linked. Good. Okay. So this is a picture of the Gower sign, a child who has to either put their hands on the ground and walk their hands up or walk their hands up their own leg, has weakness of what muscles? A little bit of quads and also their gastrocs. Good. The gastroc forms a very thickened amount of tissue. Do you guys know what that's called? Pseudohypertrophy. Good. Okay. And it's not a giant muscle. It's the fatty and fibrous infiltrate of the muscle. So their muscle's not getting bigger and stronger. It's being replaced with tissue that does not function like normal muscle. The dystrophin gene is pretty easy if you just remember it's Duchenne's muscular dystrophy. And then a common lab finding for these kids will be an elevated CPK. All right. I doubt you'll see CP on your test, but it's my wheelhouse, so I had to put a slide on there. Anyway, kids with CP have abnormal tone. The consequences of having higher muscle tone are that you develop contractures. So if you're constantly bringing your biceps in, eventually the biceps will actually shorten, and so will your brachialis, and you won't be able to fully extend your arm because the muscle shortened and then subsequently the joint on the anterior side contracted. In muscles like, in joints like the hip, you can actually get dislocations. And then we define CP in terms of where it is in the body. So diplegia is somebody who has far more affected legs than arms. They can have completely affected legs and nothing in their arms, or it can be kind of just a little more in the legs than the arms. Whereas quadriplegia, they're pretty even, top and bottom, all 4. So 2, 4, easy to remember. And those kids often have CP as a consequence of being born prematurely. So kids who are 1,500 grams or so when they're born anywhere from 20 to 30 weeks, they have a much higher risk of this. Kids with hemiplegia, so it affects 1/2 of their body, more likely had some sort of stroke. Okay, now osteosarcoma is highly testable for us, whether or not it is for you guys. So it's one of those things that you can ask a lot of questions about. There's a lot of things that are predictable with it. So it's always a good topic to discuss. So this, is there a pointer? No. All right. Oh, yeah, there it is. Here we go. So you can see the outline of a femur here, kind of, and then the tumor has just exploded out of the bone. What you also see on this picture is a growth plate. Can you guys see that right there? And I think that's an important point in this picture because it reminds you that osteosarcoma often happens in immature people. So people whose growth plates are either still open or just closed. It's very common in teenagers and early young adults. So osteosarcoma is the most common primary bone tumor. So that's a distinction that we need to make. What's the most common bone tumor in general? Mets, right, okay. So if you are asked what is the most common bone tumor, it's Mets. If you're asked what's the most common primary bone tumor, osteosarcoma. Then we feel our research has shown that tumor suppressor and oncogenes play a role in development of osteosarcoma. So P53 and retinoblastoma are what? Good, okay. The most common site to find an osteosarcoma is either in the bottom part of the femur or the top half of the tibia. And so it's almost always around the knee. We do find it in other places. In fact, I just had a conversation with our oncologist about a patient who's got it on the posterior aspect of their pelvis, but flat bones are really uncommon. So by far and away, you should think of the knee when you think of osteosarcoma. Just remember distal femur, proximal tibia. It happens more predominantly in males, but not by much. It is high grade on x-ray. So you will see bone forming on an x-ray. If you don't see a lesion in which bone is forming, don't think osteosarcoma, think of something else. You will always see bone formation. And osteosarcoma goes through the cortex. So we describe a sunburst pattern on an x-ray because it looks like it's just bursting out of the bone. If you look at a histology slide of osteosarcoma, you'll see what we call lacy osteoid. Again, it's forming bone, so you should see lots of things on a slide that look like bone. What are skip lesions? Non-contiguous. Are they in the same bone or a different bone? Same bone. Good. Okay. So if you had a secondary lesion in the proximal half of this same femur, that would be a skip lesion. Does that make it higher grade? Yes. Okay. How does osteosarcoma spread? Hematologically, good. It spreads through blood. So like when someone goes to do a biopsy of this, they have to be exceedingly careful with how they approach it, how they operate on it, how they pull it out. In fact, I would, if I had any suspicion that something was an osteosarcoma, I wouldn't touch it. Only the orthopedic oncologist gets to do that. If you're going to do the biopsy, you're going to be the person to take care of it. And so then treatment for osteosarcoma is 3 steps. Then the first and third are the same. So the first one is, I heard it, chemo, surgery, chemo. Chemo, surgery, chemo. That's the treatment for osteosarcoma. Shrink the tumor, remove what's left, and then kill the bed. Okay. So open fractures and polytrauma in general is probably the bread and butter of orthopedics. Hopefully not that many open ones, but trauma is certainly what we see the majority of, right? Well, not me personally, but it's definitely high on the list of things that orthopedics in general sees. When you have someone who has polytrauma, you have to think about what's going on with their lungs for 2 reasons. Somebody who took a lot of full body energy may have bruising or some other injury to the lungs to start with, but when you injure multiple long bones, you start throwing fat emboli. And where do they go? The lungs. Does anybody know what you can get from that? ARDS. Good. Okay. Increased risks with open fractures include infection and non-unions. So bone doesn't heal as well once you've stripped away the blood supply, which is often what happens in the case of an open fracture. In the ED, an orthopedic surgeon's role is to just cover it, clean it a little bit, but cover it, hold it still so that you don't keep throwing blood and fat into the tissues, and also to make it less painful. And then get antibiotics started immediately. The faster you start IV antibiotics, the better the person's chance. So then we go to the classification system for open fractures. It's a little tiny bit tricky, but not too bad. So a grade 1 open fracture has an opening at the skin that is 1 centimeter or smaller. That's pretty standard. That's a grade 1. A grade 2 is anywhere between 1 and 10 centimeters, and we expect that there's moderate soft tissue stripping. Now 3 is where we get into a bit of a tricky situation. So if it were greater than 10 centimeters, it's a 3. But if it's less than 10 centimeters and there's extensive soft tissue damage, so you can tell from your exam that a ton of tissue, even away from where the opening is, has been stripped away from bone, or you can have degloving injuries, so the plane of skin and fat will separate from the fascia, or if you have any vascular injury associated with this, then it doesn't matter if it's 10 centimeters, it's automatically a 3. So if you have any of that stuff, you jump to 3. If you don't have any of that stuff, then you base it on size. Okay, compartment syndrome, I talked about a little bit when I gave the lecture earlier in, I guess that was November. The 5 Ps are pain with passive stretch. The first thing you'll probably see is palpable swelling. So if you go and touch their leg and it's so tense that you can't even depress the skin in, that's a bad sign. Paresthesias, pulselessness, and paralysis all come later. So the first thing you'll probably be called for to come look at a leg is or an arm for that matter, something that's really tense and swollen. And then to differentiate between just a tense, swollen leg and one that has compartment syndrome, you passively extend the toes or the fingers. And if that makes the person want to jump up and hit you, that's a bad sign. That's probably compartment syndrome. If they don't at all and they're totally calm or still asleep, that's always a good way to tell, that's probably a decent sign. If the exam's equivocal, then you go on to test the pressure in the compartments of the leg or arm. The leg itself, the tibia anyway, or shin, has 4 compartments. So you have a posterior compartment that is comprised of the gastroc and the soleus. You got a deep posterior compartment with all your toe flexors. You've got a lateral compartment with the perineals. And then the anterior compartment has tibialis anterior. Don't write down all those muscle groups. Just know there's 4 compartments and that you could have compartment syndrome in 1, 2, or all of them. If we're testing the pressure, we want to know that it is within 30 degrees of the diastolic. So if I know that your blood pressure is 90/80 and I stick your leg and I get a pressure reading of 20, you probably don't have compartment syndrome. But if I get a pressure reading of 60 and your diastolic was 80, that's compartment syndrome. Does that make sense? Because it's within 30 of the diastolic. So anything above 50 would have been bad. There's a device called a Stryker compartment pressure monitor, and it's a little kind of pressure gauge attached to a big fat needle. No, it's like a probably a 16 gauge needle. Just for comparison, when you give blood, they use a 12 gauge, and most of the time when you see people drawing stuff out of bottles, that's an 18 gauge. So, you know, it's fat. It's not as fat as what you donate blood with, but it's a pretty fat needle, and you jam it into somebody's leg. So you hope that they're semi-sedated for that part. But anyway, you can use that. The other thing you can actually use is you can use an arterial line setup. So the thing that anesthesiologists use to monitor blood pressure in the OR, they stick a line into somebody's artery. That's a pressure gauge. It's just measuring pressure from your artery. You can use the same thing and stick it in somebody's leg. So now, when you guys are all future orthopedists and you can't find your Stryker compartment monitor, you'll know how to do it. No, nobody? Dang it. All right. So this is definitely, I think, because you guys were asked about this in IQs or SEQs or whatever acronym we used. Arthritis, you know, that's probably a more commonly testable topic. So, plus it just affects like the majority of the population over the age of 40. So when we're talking about knee arthritis, let's just start with standard osteoarthritis. So standard osteoarthritis involves people of, I said over 40, but let's be a little more specific. It involves people about what age? Yeah, older, 60, 70, 80. And one of the things that can cause it is a previous meniscectomy. But what are other things that cause osteoarthritis? Being overweight. You can have trauma. You could have a traumatic osteoarthritis. One other just kind of general thing that just happens to everybody. Wear and tear. Degenerative osteoarthritis. Good. Okay. If you're going to treat this non-operatively, there's certain devices we can have people use. Do you guys remember what those were? Cane is one, something you can add to the leg. An unloader brace, good memory. You could also have somebody use a walker or anything that just takes some of their body weight off their leg. What medications are useful for this? NSAIDs? Yep. Anything else? NSAIDs are your best bet. You can use other types of pain medications, although we try to avoid that as much as possible. I'm going to get to the mechanism of action on another slide, so we're going to skip that. If you were going to treat, ignore both those pictures. If you had a completely degenerated knee, are you doing a unicompartmental knee arthroplasty or a total? Total, right. What would make you do a uni? If only one side was affected and there's something that has to be intact to do a uni. Anybody remember what that was? One ligament. ACL. ACL has to be intact to do a uni. Now, if you had rheumatoid arthritis, does the treatment differ? Would you ever do a unicompartmental knee on rheumatoid arthritis? No. Okay, good. Is the medication the same? NSAIDs do have some role in rheumatoid arthritis, but there's a disease-modifying type of drug, otherwise known as DMARD. There's a whole bunch of them, and we're going to talk about mechanism of action for those in a later slide too. And if you had gout, how would the treatment differ? Okay. And often, if you can alleviate knee pain and gout before you get to some sort of degeneration, that's a much better situation. If you have asymmetric joint space loss, is that more likely to be osteoarthritis or rheumatoid arthritis? Asymmetric. Osteoarthritis. And if it's uniform, it's rheumatoid. Good. Okay. So in the world of pediatrics, we see a lot of cases of slipped capital femoral epiphysis, otherwise known as a SCFE. And this is a disorder of the proximal femoral physis. Anybody know what zone this is? It's a calcification zone, yeah. I forgot what I was going to say. Okay, so basically, in the case of a slipped capital femoral epiphysis, does the head move or does the rest of the femur move? The rest of the femur moves, and it unscrews. It doesn't just move to the side. It actually rotates. And it gives this appearance as though the head has tilted posteriorly and usually a little bit medially. But in actuality, the femur has turned externally and usually extended a little bit. Anyway, what age does this occur in? Ballpark. Early teens, yeah. So we start seeing it around 10. If it's earlier than that, we have suspicions about what's causing it. And how do they present? There's two kind of totally different types of presentations. They'll both have a similar rotation to their leg. They'll be externally rotated. Some will come in walking, and some will come in not walking. So if someone comes in and they complain of pain, where are they going to say the pain is? Their groin or the front of their thigh, sometimes even down to their knee. But if you see a child who complains of knee pain, think about x-raying their pelvis, especially if they're in that age range, just to not miss this. I had a kid who was one of our staff's grandchildren come into my clinic because his grandmother said, his knee's been bothering him, would you see him? And I said, sure, bring him in. And he was limping a little bit, and I don't know why that jumped. Anyway, his pain was kind of right here, and I said, well, just to be on the safe side, we'll get an x-ray of your pelvis. And sure enough, he had a slip. And he went to the OR the next day, and I made him not walk from that point forward. He went home on crutches. So this is one of those things that's easy to miss if you just don't think to order the film. So what sorts of things in a presentation would make me think, oh, this isn't just your standard overweight kid with a slip. I should work them up for something else? I gave you one a minute ago. No, age. Age was the one I just said. So if they're younger than, a young teenager. So like if you came in and you were 8 and you had a slip, something's wrong. 8-year-olds should not get slips. What else would cause me to think This is not normal. Say that again? So that's one of the potential abnormal causes of a slip. What would make you think that somebody might have hypothyroidism? In the characteristics of the child, not necessarily their physical exam. You don't have to tell me what the symptoms of hypothyroidism are. Skinny, right. So a skinny child, because typically slips are in overweight kids. So if you come in and you have a slip and you're super thin, I'm thinking something else is wrong. And then let's say that it's on one side. Is that typical or atypical? Typical. If it's on both sides, is that typical or atypical? Atypical. Good. So if you have a young child, a super skinny child, or somebody who has it on both sides at the same time, you're getting a workup. Because it's probably not just you were overweight, this was a repetitive type of injury sort of thing, or a growth plate abnormality. We believe, and I think the literature is evolving to show that people who have low vitamin D levels are at much higher risk of a single-sided slip. And that makes sense, right? We know vitamin D contributes to physeal problems. So how do I fix this? In situ pinning. So I put a screw across it. Good. All right, if you're a little bit younger and you have that same sort of pain pattern, groin to knee, you might have Perthes disease. So Perthes disease is an idiopathic avascular necrosis of the femoral head. It is also usually single-sided. If it's bilateral, something weird is going on. And it typically is seen in kids 4 to 8. The younger you are, the better the prognosis. The older you are, the worse the prognosis. Just because you have more time to remodel the bone as it grows back in if you're young. And the older you are, as it starts to regrow, the less remodeling it's going to do. Okay. So pediatric osteomyelitis can involve lots of different joints. Septic hip, I think, definitely is one of the most common joints that we see it in. Probably knees are second and shoulders are third, but there's a lot of things that look like septic hip. We get called to the ER a lot to rule it out. And so what are some of the things that mimic it? Soft tissue injury, yeah, definitely. You can pull a groin muscle and have pain in the same area. What else? Perthes in the right age, sure. What else? Juvenile arthritis is a possibility. Synovitis. Toxic synovitis, yep. That's the most common thing. If I see somebody in the ER and they don't have a septic hip, the number one thing they probably have is toxic synovitis. One more thing. Septic arthritis and well, septic arthritis is kind of the same thing. So I'll separate them out in a second. One more thing that's not an infection. Fracture. Tumor is a possibility, I suppose, always, but fracture is probably more common. Good. Okay, so if you have a septic joint, it often comes from an infection and a metaphysis in 4 of the joints. So why does it start in the metaphysis? And why does osteomyelitis start in the metaphysis? Highly vascular, but there's something about the blood vessels. Tortuous and tiny. Good. Okay. And there's 4 places where the metaphysis is in the joint itself. So the joint capsule actually extends around the growth plate to the metaphysis. And those 4 joints are the ankle, shoulder, hip, and elbow. So to deviate for a second, my favorite peds ortho attending when I was a resident was this very gruff, kind of sarcastic man who liked to make fun of other people, but would do it with a completely flat face. Like, his face never changed. And he would just, I'm sure in his head, be laughing at everything he said, but his face never changed. And there was another attending he really liked to make fun of all the time. whose name was Ash. And so when he first gave us this particular mnemonic, he said, all you have to remember, and this is what he called the other attending all the time, so it just always sticks out in my head. He said, and he always stood like this. He goes, just remember, Ash, because that's how he said this guy's name all the time. And for the rest of my life, anytime I try to remember what joints are, what metastases are in the joint, I will think, Ash. So now when you're sitting there trying to think, okay, is this joint in the metastasis? I mean, is this metastasis in the joint or not? You'll think, Ash. But there you go. So that's how I remember that. Common organisms in kids. Number 1, staph, right? Staph is everywhere. If you're a baby, brand new baby, just born, Group B strep, where did that come from? Ugh, gross. Okay. Next, you're a little tiny bit older. What's the next most common thing? Starts with an H. H flu. Good. You're a college student. Neisseria. Good. You're an IV drug abuser. Pseudomonas. Good. Okay. You have sickle cell. Salmonella. All right. But far and away, number 1, the most common thing we're going to see is staph. And don't forget that, because empiric treatment should always be for staph. Always. And I think especially, so I trained in the South, and in the South there's another bug called Kingella, which is really common. We hardly ever see it up here. But it's probably, at least in the South, a secondary organism to staph. We just don't see it in the North as often. I think it prefers kind of temperate climates. But it thankfully uses the same antibiotics, so that's good. Okay, so we'll get to that in a second. When the kid comes in and they have a septic hip, so we're going to separate osteomyelitis from a septic hip. They have a septic hip. How are they going to hold their leg? Flexed and externally rotated, right? That's the position that makes a joint most comfortable. That takes the most pressure off of the joint capsule. So if you flex and externally rotate, that feels good. If you have osteomyelitis, it's probably not going to matter that much. You're just going to have a swollen area of long bone. Usually it's near a joint, but the osteomyelitis does not present the same way a septic hip does. Okay. How is any, well, okay, let's say you have, let's start with septic hip. You have a septic hip. How are we going to treat that? We have to do at least 2 big things. Drain it. You have to surgically open and drain the hip. Got to get that crap out. Number 2, antibiotics. Okay. So septic hip requires drainage and antibiotics. If you have staph, what's the most common antibiotic we're going to use? Cefazolin, otherwise known as Kefzol or Ancef, but cefazolin. There are other antibiotics out there. Those are definitely number 1 on the list. There are certain types of staph that are resistant to that, and they might need vancomycin. But far and away, standard first-line treatment is cefazolin. Okay. Yeah.
Do you treat empirically, or do you get cultures?
If you know they have a septic hip, you want to drain it and get a culture before you start antibiotics. Sometimes they'll have been to their pediatrician, and the pediatrician will have thought something was up, but not known that it was a septic hip and started something ahead of time. That does occasionally happen, or the ER will do that before we can get there. But if we have high suspicions, we ask everybody to hold antibiotics, and then we get them to the OR as fast as we can. Okay, so let's separate that from osteomyelitis. Sorry, let's say you have osteomyelitis. Okay, osteomyelitis can require surgical drainage if something specific has happened. And actually, there's 2 somethings. Anybody know what would make me open up osteomyelitis? It's walled itself off. Okay, so antibiotics can't get into walled off area. Or one other thing, and I don't actually have to open the bone for this one, but I got to go in. A subperiosteal abscess. Good. Okay. So If you have a subperiosteal abscess or a walled-off abscess in a bone, otherwise known as a Brodie's abscess, then I have to go in and get that stuff. If I have neither of those things, hematogenously spread osteomyelitis, it came from your bloodstream, it ended up in your bone, but it has not walled itself off yet, or you don't have an abscess adjacent, just needs IV antibiotics. Okay. So let's separate those again. Septic hip needs drainage and antibiotics. Hematogenously spread osteomyelitis with no abscess, just antibiotics. Walled off or subperiosteal abscess, surgery and antibiotics. Good. Okay. Good. All right. What happens if I don't treat a septic hip? Badness. That's what happens. Badness. The head will die. It will become deformed. And we currently have 2 kids whose x-rays I see every handful of weeks in indications conference because we have to do something else to them. They just have a terrible outcome. The bone, as it becomes misshapen, eventually turns into an arthritic hip as well. I suppose we could also say that the infection has the potential to spread as well, but from an orthopedic standpoint, I think what we care about is that the bone's going to die. Okay. And cartilage damage, right? So the cartilage gets damaged by the infection. So does the synovium, for that matter. Okay, what complications can occur? Yeah, sorry.
I was just going to ask when you consider doing a total hip on a child with severe complications of ADN.
The only time we do a total hip on a child, as opposed to doing something else temporizing until they can have a total hip later, is so there's like a guy who's a little off, not off, he's a little out there, who does it in sometimes kids with CP, and he uses a shoulder replacement in the hip. Yeah, so that's one center in the U.S. I think there are a number of people who do it for people with sickle cell, but the problem is that when they were doing them more frequently, they were only using ceramic on ceramic hips, and those have kind of fallen out of the wayside, and we don't have a good replacement for them, and nobody wants to put metal on metal or polyethylene in somebody that young. This is probably going way beyond what you need to know for the test, but anyway, the answer is hardly ever in a kid. We'll temporize for as long as we can. Okay. So if I treat this, what are the potential complications? Maybe, but not usually from the surgery itself. Unlikely, but I suppose if I didn't put the tissues back together and I really did some damage to them, I could do that. You know, there's a type of staph that's associated with an increased risk of DVT. They form like these thrombus of both blood and bacteria, and then that thrombus throws septic emboli. But usually that's not a complication of the treatment itself, that's just a complication of having that particular type of staph. So I think anytime you open somebody's hip joint, you actually also put them at risk of AVN, because you could potentially damage the blood supply. If I drill someone's bone, they have a slightly increased risk of fracture afterward. So those are probably things that are more just mechanical and technical, right? Yeah?
Do you ever worry about their growth after?
Sure, yeah, that's a very good point. So an infection can damage the physis. So could the surgery if you did something stupid. But infection can definitely, if left untreated for a while, damage the physis and then cause either a growth arrest or an abnormal growth of that physis. It's a good point. Okay. So non-accidental trauma, child abuse. Most common age for this is?
Less than 1 year?
Sadly, yeah. The younger you are, the more likely. So weird things to pick up on are an inconsistent history from the parents. What they describe happening doesn't match the injuries that you see. So babies don't get mid-shaft transverse femur fractures. They don't get mid-shaft humerus fractures. They could potentially get spiral fractures if their foot got caught in their crib and they twisted or something weird like that. But they really need to have a consistent history, and they need to seem reasonable when they're talking with you. Multiple fractures in various stages of healing is very common. The number one actual finding in non-accidental trauma is what? Skin lesions, yeah, so skin issues. And then fractures are second behind that. If you do a skeletal survey, I'm just going to go ahead and say it rather than asking you guys. You're basically x-raying every bone in the body. You only get one view of each one, but you get head, you get chest, you get spine, you get one of the forearm, one of the femur. Anyway, you get everything. The common findings for trauma or for non-accidental trauma are corner fractures. So here's a good example of a corner fracture. What really happened here was somebody moved this leg in this direction so much that this ligament pulled a chip of bone off the corner. So what you're actually seeing here is the beginnings of healing, because you probably wouldn't see a fleck like that unless it was already starting to heal. And then a bucket handle fracture is basically the same thing but on this portion. So this is actually off of the metaphysis, and a bucket handle is off of the epiphysis. And then transverse long bone fractures, as I said, babies don't get those. And so here's another kind of potential scenario. They say, oh, my baby rolled off the bed. That's how they got this transverse femur fracture. That's actually a real possibility. I could see a baby rolling off a bed and getting a transverse femur fracture. But the issue is, why did your baby roll off the bed? You shouldn't have left your baby on the bed. So they're screwed either way. Okay. The differential diagnosis for this, you can see kids with multiple fractures who have osteogenesis imperfecta, right? It's all in the history. And then same thing for rickets. Rickets can be associated with some abnormal findings around the joint, but it might not actually be NAT. Okay. Bone healing. So primary versus secondary bone healing is one of those things that comes up a lot and is, I think, a little more difficult to understand. So I'm running out of time, but I'm going to spend a minute on this. Primary bone healing versus secondary indicates how much stability was present when the bone was healing. And so whether it was tightly together and it grew back exactly cortex to cortex, cancellous to cancellous, or if it used this whole kind of callus formation that then remodels into woven bone and then becomes normal-looking bone. So primary bone healing is which one? Tight end-to-end. And which of these constructs do you think would give you primary bone healing? Would the screw do it? Yes. That screw compresses those pieces of bone together. That's why it's got all the threads on this side and the big fat head over here. It's squeezing them together, and they better hold still. What about a plate? Yes. Well, that's a plate over there. Okay, so secondary bone healing can come from the nails that you see kind of in the middle, or one other big common pediatric way to heal a fracture, casts, right, good, okay. And so rigid fixation, plates, screws, relative stability, nails, casts. Any questions about that stuff? Yeah.
If you don't get kind of good closure, you get fibrosis, right? Kind of. If you
Yeah, so if I don't line them back up perfectly, either bone will go around it if there's still periosteum over it, or you can get some fibrous tissue in between if there's a pretty decent gap. And that would be probably not as stable. But when you put two pieces of bone so close together that they can only grow back cortex to cortex, cancellous to cancellous, then that's primary. Okay. Yeah. Totally depends on the fracture pattern, and that's a much longer discussion. So we can talk about that afterward if you want to. although this kind of touches on it a little bit. If you have, well, no, not really. Never mind. We'll come back to that some other time. Okay, so fragility fractures occur most frequently in people who have osteoporosis or osteopenia. So when I'm trying to think about how to explain this, if you look at normal bone in the center down there, it's all thick and it's packed together in a way that there's a high volume. So think about a tower of Jenga blocks where you haven't pulled anything out yet, right? You've got this packed tower, and if you compress down on it, nothing's going to happen, right? Because those blocks are all stacked together. Now, start pulling some out. Not to the point that it's going to fall over, but just make it have less volume. Well, then, if you push down on the top of it, at some point, especially if you've pulled out side blocks, things going to give, right? Whereas it would not have done that when it was tightly packed together. Bone is the same. So when the structures are highly integrated and thick, bone has a lot of strength. But when you start to take some of that away, and that's what osteoporosis and osteopenia are, they're a defect in quantitative bone. So we've taken away volume. We haven't necessarily changed the trabecula in the way they form, so they're still plate-like and rod-like, but we've taken away volume. And that has a lot to do with the amount of mineralization. So this is a decrease in bone formation. It's most commonly seen in postmenopausal women, but you can see it at other times. Fragility fractures involve a direct relationship between the amount of bone loss. So the more you've taken away bone, the more likely you are to get a fracture. And so this is most commonly sort of, you can get lots of fractures. Lots of people with osteoporosis get wrist fractures or hip fractures or those sorts of things. But what we see a lot of that you don't necessarily see people treated for are issues with spine compression. So you've got the anterior column where all your vertebral bodies are, and the posterior column where you have the transverse processes and the spinous process. And if you start decreasing volume in the anterior column, but you still have that nice posterior column that's still intact, you kyphose forward, right? You lose volume on the anterior side while maintaining the posterior side, and that's what it does. So the kyphosis can be compression fractures or just sustained volume loss over time. And if you get a 15% increase in the amount of volume loss, that increases your 5-year morbidity. The highest risk factor for a fracture is a previous fracture. And I hate that statistic. I think that's the silliest way to say it. But basically, once you've had one, you're highly likely to get another one. So the point of that is, should you go out and do any sort of primary care or endocrinology or orthopedics, and you see somebody get a fragility fracture, please do not ignore them. They need to be treated so that they don't get another one. You start to really decrease your lifespan with hip fractures and spine fractures. I mean, you're talking about decreasing somebody's life by not treating them. Okay, this is, I know, not a topic anybody loves, but the FRAX is an assessment tool that looks at risk factors over 10 years of your life, so it takes into account all kinds of things, everything from your gender, your age, breast cancer, your alcohol habits, eating habits, lifestyle, all kinds of stuff. And then, so that's a good assessment tool, but the DEXA scan is kind of the gold standard. It looks at your hip and your spine and how much bone density you have there, and it compares you to both people your own age and a 25-year-old. For you guys, that's not that far off, but for older people, that makes a distinct difference. Bisphosphonates are the most common therapy. Bisphosphonates work by stopping the osteoclast from bone resorption. For some reason, I also always think of Pac-Man when I think of osteoclast. Anybody else do that? It works well because it's a C shape for osteoclast, right? You have to be a dumb orthopedist to get this stuff. Okay, so osteoclasts go along and bite bone. They should then signal an osteoblast to come behind and build bone, right? Because they're tied together. So as the clast comes along, eats up bone, the blast should build it. If that process is disrupted, then you start to see osteoporosis. And a bisphosphonate helps by stopping the osteoclasts in the first place. They don't do as much for the osteoblasts. But if we can stop those clasts from eating bone in the first place, at least we can maintain some of what we have, right? Bisphosphonates are given every day or in staged patterns. They work better for bone if they're given in staged patterns. So that's why you see these commercials for Forteo, take it once a month, or whatever the one is that you take once a year. It's not because they don't want you to go get treatments more frequently. They actually work better if you give them in cyclical patterns. Okay, and they also want to make it nicer for you by not having to go in as often. Paget's disease, just briefly, it's a disease where the bone gets incredibly sclerotic because the osteoclasts aren't working at all. It can, affect long bones. Certainly, they get hard. Man, if you get a fracture in a bone with Paget's disease, I can think of people that the drill bit has gotten stuck in their bone and we can't get it back out. The saw has broken off in the bone. It's been so hot that it smoked, there was smoke coming off the saw blade. This bone is ridiculously hard. It's not easy to fix. It's hard to even get a screw into it. But it can also affect flat bones. So the problem with that is that if the bones in your ears are affected by Paget's, they don't conduct sound, right? So you can have hearing loss. And then if you develop that increasing sclerosis and closing down within the brain, within the skull, you can have lots of internal cranial problems, everything from stenosis at the occiput to vascular problems. Okay, this is the second to last slide. We are almost there. Drugs that you need to know. I said we'd talk about these. This is what you need to know. I'm not going to go over it in detail because, number one, you probably already know it, and number two, it's right there on the slide. So here's the last one. These were questions that came up last year. I dealt with primary versus secondary bone already. The other thing to know is if you're testing nerve function to the hand, there's 3 big nerves to test, both sensory and motor. So let's start with sensory. Where do you test the radial nerve? Back of the hand. Where do you test the median nerve? These 3 fingers, right? Where do you test the ulnar nerve? These 2 fingers or this side of the hand. Let's do motor. How do I test the AIN, which is a branch of the median, right? How do I test the AIN? A-OK. So if you can flex your DIP joint or the tip of your index finger and make an OK sign, notice I have to flex my thumb to do that. That's the AIN. How do I test the radial nerve function? Thumbs up. So if I can extend my thumb, or really all of my fingers, PIN is actually innervates the thumb extensor and the index finger extensor last. So you know that you've gotten nearly all the way down the path of the PIN if you can do that. But thumbs up is a pretty good way to test. And then ulnar nerve, how would I test that? Abduction and adduction of your fingers. Good. You can have somebody cross their fingers or just have them spread their fingers apart and resist you trying to squeeze their fingers together. The IQ materials are going to be crucial for your test, so pay attention to those. And wouldn't we all rather be here? I would. Okay, if you have questions, I'll stay up here for a few minutes, and then we did it in under an hour. Yay!